last one before the lunch break. So now we're having a session with Dexcom. So Dexcom is one of the sponsors of the YLD training. So thanks to Dexcom and to Novo, who were here yesterday, and to Lily, who you have seen in the program, this training is possible. So thanks a lot. And yeah, the floor is yours. You have a microphone here. I don't know if I'm there. Just remember to use them because we are recording the audio. So
Perfect. Well, good afternoon.
Hello.
It's our pleasure to be able to be here. Let me give you a quick update. This is not going to be a commercial about a technology. Our job today is to talk with you about how do you build an advocacy case in your country to get what you want. How do you build an advocacy case in a methodology to policymakers to get what you want? How many of you have negotiated with your parents as children, or when you were a child? How many of you negotiated for candy with your parents? What was the methodology that you used to get what you wanted? You didn't give up. You hounded us.
I think she had a different methodology. Yeah.
I have 2 grown daughters and 5 grandchildren. They're persistent and they don't give up until they get their way. That's called advocacy.
So just a quick overview of what we will talk through. Of course, as previous sessions, this is informal. So if you have any questions, if something isn't clear, or you have any comments, please interrupt us immediately. So as Bruce was saying, we'll talk about successful advocacy. So a bit about the secret sauce that is required to put together an advocacy program. And we will give you some examples of different countries. And obviously it's from our world, the category of continuous glucose monitoring. And at the end, then of course, we're open for discussion. But as I said, interrupt us immediately if you have questions or things aren't clear. Just a few words about ourselves. I let Bruce.
Well, for an introduction, I'm a son, I'm a brother, I'm a father, I'm a grandfather. I've been a patient with diabetes for almost 45 years. I know what it's like. When I was first diagnosed, I was given urine strips, glass barrel syringes you had to boil, soak in alcohol, and give injections of human or pork insulin. The world has changed dramatically in that 45 years because I've enjoyed to watch the history of what's happened with newer medications, newer devices, all the breakthroughs in scientific technology. I like to compete to win. My father told me growing up, be world class, but don't be half-assed. If you're going to go into an effort, do world class. So in my younger days, I was a world-ranked competitive powerlifter. Irony in politics, Jimmy Carter canceled the U.S. participation in the 1980 Olympics after I made the team. That's called a setback, but you just have to keep going. But more importantly, I'm an advocate. I fight for what I want. You want candy? What did you do to get the candy? I want devices. I want insulin. I want SGL2s. I want, and I ain't giving up till I get what I want.
Okay. So you can see on the upper right-hand side, I'm a bit sad today because we lost disastrously last night against Portugal. Just a few words about myself. I'm also a father. Fortunately, I don't have diabetes, but I've been in the diabetes world for a long time. So the pictures on the upper left-hand side, that's actually, I was taken as a model with the small startup company called Minimed. Some of you may have heard of it, so that's the company that actually invented continuous glucose monitoring. And you can see a prototype of the insertion tool. At the time, insertion tools were like total breakthrough and a new thing. Of course, today it's just a total normal thing and no big deal. And the continuous glucose monitoring was like, it had a cable, it only worked for 3 days, it was blinded. You had this big fat needle, which was quite painful to insert. I tried it a couple times myself. Then I actually spent some time in India. That's the picture in the middle. So I was living in India for 4 years and introduced pump therapy and continuous glucose monitoring there. So I have a bit of the perspective of, let's say, the European world, the US, Northern American world, but I also have the perspective of a developing country. So there you can see us, that was the tiny team that was working with local partners and doctors and patient organizations, trying to launch pump therapy in India. I've spent a considerable time also, that's the upper right-hand side, that has nothing to do with diabetes. I was in the field of epilepsy. This is epilepsy surgery. It was a company that made a robot that helped surgeons to put electrodes into the brain to try to cure children with drug-refractory epilepsy. And then recently I came back to the diabetes area and joined Dexcom and Bruce's team. And my responsibility is basically market access and government affairs outside of the US. And if I'm not working, I like to be outside with the family and dog, and I'm quite a fan of fishing. This is my son with one of his most recent catches, and I live in Switzerland near Geneva. Bruce.
So one of the things that I wanted to bring to, when I talked about tenacity, I'm going to give you a quick case study of what happened in the US to be able to get CGM covered. Now when I say CGM, it wasn't a fight for Dexcom, it was a fight for the category. In my role and in Adrian's role, we are product agnostic. We fight for the category because no one in here is the same. My diabetes is not your diabetes. My dose of insulin is not your dose of insulin. What technology you use for your lifestyle may not be the technology I need for me. So you need choice as a patient, and your physician needs choice to tailor what's most appropriate to you. So when we talk about policy, this is a stair-step approach. And when you see the CMS administrator's ruling, what happened in 2016, what this chart doesn't show is for the 10 years prior, all the trips to Washington, D.C. to talk with the FDA, the Centers for Medicaid and Medicare Services, not only to get approval, but coverage. How do we get patients access? Once we got the administrator's ruling, then each one of those incremental steps were additional changes and advocacy efforts from a team of advocates that represented patients, suppliers, physicians, manufacturers. So we had the stakeholders of the diabetes community when we went in. But this is an ongoing process. Every incremental gain is a win. But it's like a long sports season. I felt sorry for Switzerland. My apologies for, but you know something, we got next season. We have the next match. And you have to keep that mindset.
By the way, I see people are taking pictures of the slides. As far as we are concerned, the slides are fully available, and you're more than happy to share them, of course. So. Yep. I guess it's not necessary to take pictures because you'll get the slides anyway. Is that correct?
Yes. Can we just ask for a favor? Can you please speak closer to the mic?
Okay, yes. No problem.
All right.
Sorry.
So when we were going through this process, one of the things we realized, we were doing a lot of things And you have to, when you go to policymakers, when you have coalitions and you have the stakeholders at the table, it's easier for them to say yes because they feel the weight of the diabetes community coming in. As young leaders, one of your goals should be, how do I get a choir singing the same tune I'm singing to policymakers, other patient advocates, professional societies and organizations, diabetes advocacies, parents of children with diabetes. So we created what's called DTAC, the Diabetes Technology Access Coalition. And then since then, you can see the incremental gains we've had in coverage policy.
And how can we convince all the policymakers that it's worth it?
Yeah. So the example of France is quite typical that basically you cannot go in and ask for everything right away. And so it's kind of a salami tactic. You go slice by slice. And it's better to have access to some people, high risk pregnancy or people with complications, get access to them, show that it works, and then keep fighting to increase it more and more. And actually right now we are negotiating with the French government to significantly increase the number of patients who have access. So there will be some good news coming.
I know you're not a charity, and in the end, the company needs to make money, but there's so many countries where they don't have access to CGM, and in a way, we're also there's an evolution with how we see companies, and that maybe now companies are not just to make money, but also to have a positive social impact. Is there anything planned at Dexcom to make CGM available to countries where it's not, to low-income countries, to countries where you might not make money, but that you would do it because it's fair? And in the same part of the question, I feel like every time there's a new generation, I'm wondering what's happening to G4, G5, G6. Like every time you get a new generation to launch into a market, would it be possible to offer all those older generation maybe to countries where there's no access at all?
Yeah, so the way we try to approach this is not keeping old products alive. That's also a nightmare from a manufacturing point of view. So what we did instead is with Dexcom ONE, on the current series, launch a less expensive, simpler product that is affordable to more countries. So, you know, like keeping old products alive and selling them or giving them away, that's not a feasible solution. Also, you know, parts in your product may become obsolete, standards are changing, you may not be able to sell them. So there are limitations to that. So instead, our solution is to have Dexcom ONE on the current series, and we're planning to continue that with each new series that we're launching, to have a Dexcom ONE version of it, so that we can address this. What we don't want to do, I mean, it has to be, you know, sensing is something you have to continue to do it, right? It doesn't make sense to give a sensor to somebody and then, you know, great, now you know what it would be like, but there is no support in your country, maybe the doctors aren't even trained, that doesn't work. So in our view, the better solution is to have a more economical version, and basically to help in the fight with governments to pay for it. It's the job of the politicians to make sure the voters are covered this way, and it's paid for locally.
Mine is not just it's not like a question, it's more like thinking of to do. When in Croatia we started to getting any kind of sensors, they were available only for people with severe hypoglycemia.
Yeah.
And in that case, like everybody has severe hypoglycemia at least once a year or something like that. So we basically ask endocrinologists to write that we have experienced severe hypoglycemia to get any kind of sensors.
Yeah.
2 years after, the policy, the government of Croatia said that they will try to taking the driver's license, license, because we have severe hypoglycemia written in our reports from the doctor.
Yeah.
So just to be careful when you are, not only you, but all of the.
You are saying it to everybody,
to everybody,
right? Yes,
yeah.
yes.
We had a huge fight with government because of that we needed to put that, but like everybody have severe hypoglycemia, but with sensors, now we don't have them, but we needed like almost 2 years to convince them that
that it's okay
without
for you to drive,
yeah,
because you're managing it well.
yeah. But for the ones, like, it was basically a stupid rule to put, like, if you have severe hypoglycemia, you cannot have, this is the only excuse that you can get any kind of sensors. So
Yeah.
just as
I have a similar story. When I was working in India, the Indian Airlines basically didn't allow any staff on the aircraft with type 1 diabetes, and then I think they were convinced once air hostesses, what's the proper terminology? Not air hostess, flight attendants. Sorry, yes, I lack in my English vocabulary. Flight attendants. And now, yeah, if somebody has an insulin pump or is otherwise managing their diabetes with good technology, they can actually work on the airplane. So I think you probably all have similar stories like this in your countries. Good point.
So mine isn't a question, it's a suggestion. I wanted to thank her for bringing up the issue of unavailability of CGMs in low-income countries. Where I come from in Uganda, for the last 15 years, we didn't even know CGMs until recently. And it was because a program had recently started giving them out. It's still in trial phases, but these are limited to only children under 12 years. Yeah. Personally, I've been using syringes and vials for over 15 years. I've had type 1, and I didn't even know about the fancy tech until recently. So it would be very important if you can look into that, because right now we only have one type of CGMs, and the only ones that even cared enough to make it available for free. But there are a few patients that can actually afford CGMs, but there is absolutely no information. You can't even try. There's nothing. You could do all the research you want, but there's even no contact if you wanted to actually purchase it. The only nearest country is South Africa, and the expense is still so high. So if you can look into that, introduce these in especially the low and middle income countries. There are a few people that can afford no information at all.
Thank you.
So, I'll have to follow up with her. So my next question is, like, if a country, like, if you're not sending these CGMs to, like, specific countries, can the patient or so forth travel to a country that is actually producing it to get it done, or do they have to be a citizen of that country?
I mean, we are well aware that people are traveling around, and not just for continuous glucose monitoring, for anything health related. People are traveling if they feel that somewhere else something is available. and they're not getting it in their country. So I cannot make an advertisement for that, but it's the reality. We know that.
And we both get calls frequently from constituents in outside countries where they don't have access, with how they do access it, and because of our networks of friends, we work very diligently to try to help them within the networks to be able to acquire it. But it's not a formal government program. It's not a formal corporate program. It's I have a key endocrinologist around the globe and say, hey, I've got this issue here. Can you help me? And we just help them connect them to people.
So thank you for the presentation. As I understand from you that there are some, barriers or challenges in launching CGMs in lower and middle countries, especially in India. So I would like to know what are those major barriers and challenges, and if there are any ways to mitigate those, and how can we can support as organizations working in India so that you can launch CGMs and it is available to more and more people who really need that technology.
Yeah.
But it's just that they do not have access, they do not have means, so they're not able to use those medical devices which others can, and that is affecting their quality of life in a big way. So how can you make that accessible, and how can you mitigate those solutions if there are challenges available?
So related to India, I have good news for you. India is really high on the list of countries that are going to be next. And I'm still in touch with a lot of the doctors I used to work with when I was there. And they have seen a presentation about Dexcom ONE. They came to us and said, hey, you're planning to launch? Yes. Dexcom ONE is perfect for us. Please bring that product to India. And so we are. I've been thinking about barriers to entrance. Some of them are not barriers that you can do much about. Complex languages or a complex regulatory situation. That's difficult. That's difficult to change. I don't really see, how you can have a big influence on changing that. Other than pushing companies, sending the companies email saying, hey, bring your technology to our country. That's really the best way to do it. You have the question?
Very quick. Is Mexico in the same situation? I mean, we are almost like neighbors.
Mexico, I'm not sure what our plans are.
If you look at South America in general, as we're sitting here, there is a major endocrinology meeting, which is all in Spanish. It's being held in Miami by Jaime Davidson. And the key endocrinologist there, I was at that meeting a year ago. They all have my email addresses, and I've become pen pals with like 10 different countries. All with their insistence about how can we move this to Costa Rica, Venezuela, Mexico. So we're in that piece, but this may be the way to answer the previous question. What is the fully cost burden of a patient with diabetes? Because the government that's what the government expense is. When you invest in technology, if you can reduce hospitalizations by a half, you can reduce the cost. When you go to CGM, you're not using strips as much. When you reduce hemoglobin A1C, a 1-point drop in hemoglobin A1C lowers overall healthcare costs by 5 to 6%. Because unfortunately, diabetes is a gateway disease. It's a gateway disease to atherosclerosis, kidney, amputation, blindness, all these other things that we're working like hell to prevent. But when they start seeing the cost offsets, because they're going to look at it through a financial lens, it's an investment, not an expense. It's an investment in their people. And that's where we spend a great deal of our time building that story, and we're here to help you with that.
And Dexcom 1, we did the translation into Spanish. So I think that's good news for, except Brazil, for the Latin American countries, that at least the language we already have. So, you know, Mexico is probably on top of the list of Latin American countries.
But I think we're getting up close towards the top of the hour, and I think all of us want to take the opportunity to thank you at Dexcom for your support of this program, and also for being able to engage, willing to engage in this discussion, which we understand is not easy in terms of access and making your products available. We have a lot of eagerness amongst the group, and we appreciate you being willing to engage in this meaningful conversation. You know, when of some of the slides that you presented, one of the ones that really resonated with me, Bruce, was when you were looking at the timeline for advocacy. And I remember I can't remember what year it was, but the FDA meeting where Dexcom had really brought in patients and families to tell their stories. And I thought it was such a wonderful example of advocacy for industry to lean on people and their problems and help them communicate that to our governments. So I think this is why we want to continue working with you, and let's all give them a round of applause for being here and for their support. Thank you.
Thank you. Thanks a lot.
My ultimate objective is that I want a global choir. The fact that you signed up for this, you're part of the choir. We're here to help. Don't be bashful about reaching out. I'd like to retire one day, so you're the farm team. Somebody's got to take Adrian and I's place. So we're here to help. And we really appreciate the opportunity to be able to chat with all of you. Thank you.
Thanks for giving us the opportunity.